Hello and welcome to Your Health Matters. You're watching Sun 20 TV and I'm Sherry Einhorn. We have a great show for you today. We're going to start right off with our first guest. Joining me today is Tammy Ashley. Tammy, thank you so much for joining us. Tammy, you are a registered nurse and the administrative director of the Wound Center at Stony Brook Southampton Hospital. Why don't we just start off with the basics? What exactly is a wound center? And I assume it has a specific purpose, yes?
Yes, it does. Thank you for inviting me to the show. I look forward to having the morning with you. The Wound Center was established sometime about 15 years ago and at Stony Brook Southampton Hospital. It is an outpatient unit that is housed within the main campus, right, in the main part of the hospital. We see patients there who have wounds, and we take care of them for many weeks at a time. It does take a while for people to heal, minimally 4 weeks, and sometimes much longer than that, depending on all of their health issues. The process is very simple. When they come to the Wound Center, we take them through what is required of them. It is a team collaboration between the physicians, the nurses, and the patient.
Why did the hospital feel the need to establish a separate wound center as opposed to treating patients either in the community or as an outpatient at the hospital directly?
Well, initially wounds are treated by primary care physicians, but sometimes wounds are very stubborn in healing. And at the Wound Center, when it was established by a group of doctors who recognized the need to have more extensive services for wound management that the primary care provider just isn't able to do in their office. So I was not here when that all started, but I do know that Dr. George Kekison was very key in getting it going at the hospital. And he saw the need to give better care, not better care, but more extensive care for the patients. And so it was launched with the assistance of a group that already had experience. And then eventually the hospital took over the whole program. And I was hired there 3 years ago to run the program for them.
Now, when you talk about wounds, you're not talking about a cut on your finger or a cut on your foot, or are you?
It sometimes could be that simple. It could start that simply. We see a lot of patients with a traumatic wound, which was maybe they fell and scraped or opened up, and they've, you know, usually all of us try to heal our own wounds at home, right? We put a Band-Aid on it and think that it's going to be better, but sometimes they just don't heal. Patients' nutrition is important in wound healing. Blood flow is important. The older we get, our blood flow is diminishing, so we don't get those nutrients to the wound to help heal them. After 3 weeks, that traumatic wound is classified as a venous wound and may need extensive treatment, which we can offer at the Wound Center. The other types of wounds that we see are diabetic foot ulcers. Diabetics also have many challenges with their health, and they're trying to find an equilibrium in their body to heal these wounds is challenging because they also have to deal with their blood sugars and make sure that they're not too elevated because that also impacts wound healing. So it's a very fine tuned operation to heal wounds. We also see patients with arterial ulcers. We see patients with what used to be called decubitus ulcers. Now we call them pressure injuries when patients are on their back or their sides where bony areas are. There's a lot of pressure and there tends to be breakdown, especially with a compromised patient.
I have a whole bunch of follow-up questions, but I'll try to go in some sort of an order for you.
Okay.
So how does one know if you need to be treated for the wound? Like you said, most people slap a Band-Aid, maybe some Neosporin, some first aid spray, and call it quits. How do you know when you need specialized care?
What happens with patients when they come to us, they'll say to us, I've been trying to heal this wound for weeks and it just isn't healing. or they'll go to their primary care. The primary care may work at it, trying to heal it, because they do have some more advanced items that a patient wouldn't have access to. And once they can't make it any better, they will send it to the wound center. They'll refer it usually to one of our physicians.
And so what do the doctors at the wound center do as far as specialized care once a patient gets to you guys?
So they do an evaluation. Like every visit, we start with a history and physical, and then we find out what their medications are, how the injury occurred. If it's diabetic foot ulcer, we know that it's diabetic related. You know, with diabetic patients, very often they can have a stone in their shoe, and because of their lack of feeling or neuropathy, that stone will cause pressure, but they won't feel it like you and I might feel it. And that constant pressure can cause a wound to erupt. So that's with the diabetic. With the venous and arterial ulcers, other things come into play, and again, wound healing is very challenging. So ultimately, a patient will get to us for treatment.
And explain some of the types of treatment that would happen that would be more extensive than either at-home care or primary care physician.
The doctors, depending on their specialty and what their training leads them to, and I will tell you that we have specialists in general surgery, vascular surgery, podiatrics, and in infectious disease. They all work collaboratively with each other, along with our nursing staff. If a patient presents with a foot wound, any doctor can see that patient, but the doctor may feel that the patient needs a podiatry consult, so the doctor will send for podiatry. If a patient presents with vascular issues and the podiatrist sees the patient initially, they'll send to the vascular or the general surgeons to review the patient's history. What we do at the wound center, and all of the doctors are able to do these, is a debridement, what we call a debridement, which is basically cleaning out the dead skin and making the patient bleed so that we get to the new layers of skin to help promote the healing. We also have products, first I should backtrack and say, assuming that a patient doesn't have an infection, we can move to the next step. If a patient is infected, then we have to heal that infection first with antibiotic therapy. Sometimes patients can use oral antibiotics. Many times we have to have them put into
topical,
not IV. IV, okay. Because some of these wounds can be very challenging in healing, and it's better for the whole body to treat them systemically like that.
What makes it so challenging? You've used that word a couple of times. What makes wounds so challenging?
It's the patient's whole being. It's their, when we see many of these wounds, they're in older patients, and the older we get, healing takes more time, vascular changes happen, so we don't get the blood flow that we want. We see malnutrition in many of the older population. People who are single, living at home alone, don't eat the way we eat. Eating is a very social activity, and when you're home alone, you tend not to do that. I found even for myself when I was living, my husband and I were living in two different places because of work schedules, and I found that I wasn't eating the way I would if he was there. So I understand where an older person who's living by themselves wouldn't do that. So we have to look at their nutrition, we have to look at their blood flow, we have to look at if they're diabetic and what other health challenges they may have. Some of them have chronic obstructive pulmonary disease, so their oxygenation is limited. So all of those things affect wound healing. So that's where the challenges come in.
A lot of puzzle pieces there to put together.
A lot, and it's very important for the physician staff, along with the nursing staff, to look at all the pieces so that we treat them correctly. The other things that we can do for the patients is we put what we call, the common term is skin subs, but it's cellular tissue products. They are made from amniotic tissue. It's actually, some of them are living cells, some of them are actually freeze-dried and shelf-stable. So I have them in the closet ready to go when the patient,
oh, wow.
Yeah, when the patient comes. That technology changed over the last few years, so we're able to have them at our hand ready to go. If the doctor decides they want the living tissue, that is ordered on a per-patient basis. So once the wound is cleaned up, there's no more infection, then the debridement will occur every visit, and then that skin tissue will be laid on top of the wound. It will be dressed with the appropriate dressings determined by the physician for that visit. There are things that keep the wounds dry, there are things that keep them moist, and then we have a covering which is generally a foam dressing that puts a little padding on it, and sometimes we have to use more extensive dressings where we put what looks like a little cast. It's called an Uniboot, and that keeps the patient from messing around with that whole leg and leaving it still, and every week they come back.
Is there a point where you might use a hyperbaric chamber for wound healing?
Absolutely. There are certain diagnoses, like a diabetic foot ulcer is one of them. Patients with osteomyelitis, which is a bone infection, those would also qualify. Those are the two diagnoses, and there are more that qualify for our specific wound patients. But hyperbaric treatment is also used for patients who have carbon monoxide poisoning. Right. If they've had surgery and the wound is not healing, we call that a failure of their flap, and we can put them in the chamber for that as well.
What is it like inside the chamber? I haven't been in one in years, story-wise. Can you describe it?
If you've ever been in an MRI, it's kind of like that. It's a long tubular system, but the advantage to the hyperbaric chamber is it is clear. You have clear glass all around you, so you're not so claustrophobic, for those of us who are claustrophobic. We have televisions that are outside the chamber. The patient can tell us what channel they'd like to watch, so that can give them distraction. But other than that, they can't bring anything into the chamber. There's no cell phones. We give them special linens to wear, all so that there's no chance of static electricity building.
Right. Is hyperbaric treatment covered by insurance?
Yes, most of the time it is, as long as it is a approved diagnosis for the hyperbaric chamber. And the Center of Medicare and Medicaid Services really drives that bar. You know, they tell you what's approved and what isn't. Right. And once they approve it, generally the other companies do too.
And what do you hear from patients, whether it's hyperbaric treatment or the other specialized wound care that your center provides, for patients who have not been able to heal a wound when it finally starts healing? I assume it's a huge sigh of relief.
First of all, I want to say this, and I'm going to brag a little bit. I have the most animated nursing staff in the entire hospital, and I've worked with many of the departments, and they're all terrific. But literally, these women are cheerleaders, and I have all women. So not that we don't want men, but we just right now have a female staff. They get to know the patients because they come on a weekly basis, which is an advantage that the inpatient population doesn't get. They're there for 3 days and then they're gone. But we see these patients for months on end, and we get to know them, their families, their likes, their dislikes. And I will say that at the end of their treatment, when we have healed out their wound, many of them are absolutely sad about leaving because they've had such a great experience, and I'm very proud to be a part of that experience. The physician staff equally are cheerleaders. They're very kind to their patients, and you know, they give them encouragement as well. So it is a good experience, even though something not so good brought them to us.
Okay, well, it sounds like you have amazing staff, which definitely makes things even better for patients. Tammy, we want to thank you so much for joining us. Now, if anyone is interested in learning more or making an appointment, we have a phone number for you to call. That is 631-726-8444. And we will be right back after we take a short break. Please stay with us. Welcome back. Thank you again for joining us today. You are watching Your Health Matters. My next guest is Dr. Raj Grover, a board-certified and fellowship-trained podiatrist. His practice helps those with acute and chronic wounds, employing various different techniques. We're going to go right to you, Dr. Grover. Thanks so much for joining us.
Absolutely.
Can you tell us a little bit about your practice to start us off?
Yes. So in regards to podiatry, I practice in West Hampton, Hampton Bays, and Riverhead, where I see anything related to the foot and ankle. So ingrown toenails, plantar fasciitis, ankle sprains, I see them in the office as outpatient. In the hospital, I see inpatients who are admitted who may have foot pathology that I get consulted on. And in the hospital is also the wound care center. So it's very convenient for the patient. Where I see them inpatient, they could just follow up as outpatient, the same facility I saw them in. And I also perform surgery at the hospital as well.
So I actually, when I was younger, had a lot of ingrown toenails.
Yeah.
Right? Can you talk a little bit about that? And then also, I think people hear a lot about, at least I do, plantar fasciitis.
Yeah.
If you Google, I know you're not supposed to do that when you're a patient, but I think people hear that phrase a lot. Can you explain maybe those two to start us off?
Yes, so ingrown toenail is basically growth of the nail plate, the hard part of the nail, that grows into the side of the skin. Usually it becomes painful, it's deep enough where it's our nails are very highly innervated. So it becomes painful, and if not treated properly, it can get infected. So I usually recommend my patients, if they start getting the pain, come right away, where I can do a simple procedure compared to a more complex procedure requiring anesthesia and completely numbing the toe, and it just makes it easier for the patient and a more pleasant experience for them as well.
What causes ingrown toenails?
So there's a lot of factors that come into it. It could be your foot type, the way you walk, your shoes, your family history also makes a difference too. Yeah.
What about plantar fasciitis? I feel like that's something a lot of people talk about.
Yeah, it's most common pathology podiatrists see, all right? And what it is, it's a heel pain that usually starts after a long walk and the patient wakes up in pain in the heel. And it's like dull, achy pain on the heel, and it can be sometimes sharp because there's nerves that run by it where it occurs. And usually we try to tell our patients to wear more comfortable shoes. Sometimes that doesn't work, then we go more towards aggressive injections, and maybe if it's still not working, physical therapy and surgery may be required.
How does someone know the difference between I took a long walk and maybe I overdid it and I'm wearing not great supportive sneakers, or I actually need to see a doctor?
So it's a duration of the pain that will, so if you overdid it, the pain should resolve in the first 2-3 days, but plantar fasciitis, if not treated properly, it will continue for weeks, and you want to start the treatment sooner than later.
And so talk a little bit more about the ankle injuries that you deal with, and connect that to the wound center and how you do that.
So the ankle injuries, ankle sprains and so forth, they need to be treated properly, right? Because sometimes what happens is the ligaments can tear around the ankle, and they need to be immobilized in order to make sure that they heal properly so the patient does not get reoccurrence of them, right? As in terms of wound care, there's a lot of pathology that comes along with the ankle and foot, in terms of that if patients have venous ulceration, they can have a lot of edema in their leg. And it may not be a problem initially, but if they're walking down the street and they stub their ankle on a bed, right, that can cause a wound that can lead to a long time of healing, because there's so much edema that needs to be taken care of before the wound heals.
Edema is swelling, correct?
Correct.
So I think sometimes people, you stub something, you twist something, and you just sort of try to go on with your daily life because sometimes people don't have time to go to the doctor or don't think it's that bad. Yeah. Bad choice? It
is a bad choice, because simple stubbing your middle digit of the fifth toe against the bed, and most people think, oh, it's nothing, it's going to get better. You'll be surprised how many times I order an x-ray and there's a fracture there. Really? Right? And patients like, oh, this happened 2 weeks ago, the pain is not going. It's because it's a fracture, it needs to be treated properly.
And so if you don't seek treatment, ultimately what happens there?
So what happens, the pain can become chronic. And there's other like non-unions and other things that can arise, which I won't get into detail.
So if a wound is not healing, though, and it's maybe from an ankle injury, a foot injury, a stubbed toe,
Yes.
What do you do for that? How significant can that turn into?
It can be, if not treated properly, when a patient is trying to treat their own wound. And usually if the patient acquires a wound, you see increase in pain, drainage, and the wound's you see the size of it. But if they're self-treating it and the drainage is not improving, the size is getting bigger, it's looking dusky in the center, that's a sign that the patient needs to see a specialist, right? If not treated properly, it can get infected, and that can lead to a whole cycle of other IV antibiotics, more resources, requiring it, doubling the time for wound healing to occur.
As you well know, people are very busy and sometimes don't have time to wait to see doctors.
Yeah.
Once somebody calls the office, you have multiple locations.
Yes.
Roughly how long before they can get an appointment? Is it months or?
No, it's not months, but it's weeks, I would say, because I'm getting booked up, right? But I would say about 2 to 3 weeks, we usually are able to fit a new patient in.
And what are you hearing from patients? That's actually short when you consider how long sometimes it takes to see a specialist.
Yes, so the thing is that knock on wood, I've been getting good results with my patients. So I see them for a problem, and it usually resolved very quickly, so they don't need to follow up. So that's why I'm able to see my new patients quicker.
What about emergency cases?
Emergency cases, I see them in the hospital. So, where they come in, they usually have infection in the foot that needs to go into the operating room to get cleaned up and may require an amputation because the patient might be getting septic, which is meaning that the infection is going to the bloodstream and they need long-term antibiotics. And at that time, the goal is to get the infection under control before it gets worse. And it is getting worse if they have patients comes in with fever, nausea, vomiting, chills. That's when you're concerned that the infection may be in the bloodstream.
What do you see most often? You can separate them inpatient versus outpatient or hospital versus practice.
Most often inpatient, I see diabetic wounds on the foot. Right? In the podiatry side, I see plantar fasciitis, ingrown toenails, ankle sprains that are very common. Any arthritis related to the foot, that's when we usually come into play.
Difference in the age groups as to what you see more often?
So the younger population tend to have more ingrown toenails and plantar fasciitis because they're more active and they want to go on long walks. Right, and the older population is more about wounds and arthritis, more of their pain.
We started talking with our previous guest a little bit about bed sores. Do you see those as well, and in what capacity, and then what's your advice to patients for that?
Yes, I do see them very often. We call them pressure injuries, right? And what they basically is that if you take your thumb, you see it's red, you have good blood flow. If you put pressure on it, you can see that it kind of pushes the blood flow away. It becomes pale. Imagine leaving that pressure on for 2-3 days. The skin is not getting its blood flow, nutrients, it will start dying. If the pressure is not relieved early enough, it could go to the deeper layers. So that's why it's highly recommended that these patients who are bedbound for a long time, they need to change their position every few hours to prevent these types of injuries. And patients who are most prone to are our elderly population who have underlying medical condition that increase the risk, especially malnutrition, incontinence, all this comes into a play.
So if an older patient is bedbound for an extended period of time, I'm guessing it's likely they would not be the one to notice the pressure injuries. So how do caregivers pay attention to that?
The caregivers, there's usually scales that they use. They monitor the position that the patient is in, and they usually have a duty of every 2 to 4 hours or even longer to change the position of the patient. And the most common places they are on the pressure points, such as the back of the head, your lower back, the shoulder blades where there's bony prominence, side of the knees, and the heels. And they need to be offloaded.
At what point would you recommend or prescribe hyperbaric treatment? So
hyperbaric oxygen treatment is, I gotta say, is a great in-adjunct treatment we have with our other treatments that we provide to the wound. And usually I recommend them for patients who have wounds that are not healing and not responding to standard of care. And usually they have underlying bone infection, which significantly slows down wound healing. There are other indications such as necrotizing fasciitis, which is severe infection of the soft tissue, can lead to amputation or limb loss, and that is when we recommend hyperbaric oxygen. There's new indications coming out like traumatic brain injury, carbon monoxide poisoning. All these are coming out now. They've been out for the past decade, but it's more advanced now because new studies are being done on how they help the patient.
Can you explain, maybe for people watching who don't understand, what is hyperbaric oxygen treatment?
Yeah.
What level of oxygen is it, and what is it about that does so well with certain types of wound injuries? So studies have shown wounds require 2 to 4 times higher oxygen concentration, right? And what hyperbaric oxygen is that when you have it's basically a glass tube, right? And your patient sits in it for about 2 hours at high concentration of oxygen and pressure that pushes the oxygen into the bloodstream and delivers the oxygen to the wound site, helping it heal. And that helps form the wound with more blood vessels at the local site, increased growth factors, and that's how it usually helps. Is hyperbaric therapy contraindicated for any type of patient?
Yes, a patient who have a history of a pneumothorax, basically collapsing of the lung. If they hadn't passed in a high risk, that's usually contraindicated. Any
age difference between, can kids go into hyperbaric chambers?
That's a good question. There's no age limit, right? And I don't see any, I'm not sure about that actually.
Okay.
About kids. I don't treat the young population in wounds, so it's not very common on them, but that's a very good question.
And so hyperbaric therapy, is it new, but is it also still evolving?
Yes, because there's new research and the indication list is growing and growing day by day, basically because it's just showing so many benefits to the patient and it's just getting more accepted now. And so
you had mentioned anyone who would be at risk for the wounds. You did say it was the older population, right? Okay, but younger folks also because they're pretty active.
Absolutely, absolutely. Okay. If they have a chronic wound, especially a diabetic, that makes them qualified for the hyperbarics.
And so really just your advice for folks who are watching as far as injuries is what?
My advice is that if someone is self-treating their wound, right, and there should be seeing a decrease in size, decrease in pain and drainage, if they're not seeing any signs like that, they should go see a specialist, their primary care doctor, or go to a wound care center. You don't need a referral to come at the wound care center, and just get a professional opinion, see why isn't the wound healing and what can you do to make it better.
Okay, and that was a great segue into me giving you the phone number to call if you would like to make an appointment or get more information. That number is 631-405-3325. Dr. Raj Grover, thank you so much for joining us.
Thank you, my pleasure.
We appreciate your time and we appreciate you watching Your Health Matters on Sun 20 TV. Have a great day.
Funding for Your Health Matters is provided by Stony Brook Southampton Hospital. As part of the Stony Brook Medicine Healthcare System, Stony Brook Southampton Hospital is committed to providing world-class academic-based medical care to our entire East End community.